excuse me, I'm just gonna have a drink. And it will then match that reconstructed image from your CT with the image that you're getting on your MV, and tell you where you have to move your couch in order to align those two images together. And then in most cases, the table can even automatically shift. So you don't even have to go into the room to move the couch. So this is just a table with a little bit of a summary about the difference between EPID imaging and film imaging for MV. So EPID, obviously, you get an immediate result. EPID is sensitive to dose rate, and you need a specific number of monitor units to create a good image on your EPID. More monitor units than you need for film. But you can get digital image enhancement. So if you have artifacts or your image quality isn't great, there are ways you can enhance the image. Excuse me. And if you want to, you can create a hard copy. So if you want to have paper copies with your patient file, you can also do that. With film, we've talked about processing time can be time consuming. Film is sensitive to total cumulative dose, and we need to consider the patient thickness. And we can't enhance a film image once it's been taken. And
what about
you only really get a hard copy. Okay. Sorry, I just need another drink.
Yeah. While you do that, do you think we can buy
questions?
2 or 3 good questions that have been coming in the last 10 to 15 minutes?
Mm-hmm.
Very good. So the question, first question is, what will be the effect of a bolus on a chest wall setup that has not been placed well in contact with the skin? So that's a little bit more going back, not the OBI, but more the changes in density and the impact on those.
Okay, right. So if you've got bolus on your patient and you haven't placed it correctly, well, look, it would depend on the thickness of the bolus and where it is on the patient and where it was supposed to be on the patient, I guess. So let's say you've got a 0.5 centimetre of bolus on your patient, maybe for a chest wall or something like that. If, let's say, maybe you put it on the wrong side, or I'm not sure what you've done, you haven't put the bolus on, for example, you've forgotten. Okay, that's probably more likely. You've forgotten to put the bolus on for treatment. What happens for that particular fraction is you probably have, well, because you're going to have less bolus, so you're going to have reduced skin dose, and the dose is going to be deposited deeper into the patient. Not an awful lot, though. We're talking about 0.5 centimetre of bolus. And you're also, hopefully, this only occurs for a single fraction. So if you're talking about 1 fraction out of 25 for 5 mils of bolus, it's not great. I'll say that. It's not great. Let's try and avoid doing that. But I think if it was to happen for 1 fraction, there's probably not a realistic way that you can compensate for that in alternate fractions. I think you just end up with probably slightly deeper dose deposition in the patient in that area where you didn't have the bolus. But hopefully it's only for a single fraction, so overall the dose distribution wouldn't be too much different. So.
Very good. Second question was, what about the metallic prosthesis in the field of GTB, like in a pathological fracture in the bone of any cancer or in bone of soft tissue sarcomas?
Maybe, Sergey, maybe you're better to answer this. You're a radiation oncologist, right? I think this should be a team answer. Yes. You know, from a physics perspective, I guess, look, if you can't avoid it, you just have to deal with it. And I think, like I said before, if you can contour everything and apply correct densities and things like that, then you're going to get as good as you can get. You're just going to have to understand there will be inherent uncertainties in your dose distribution. in that particular area. So, and if you can avoid it, although you probably can't, like if it's only part of the bone, like if it's if you've got like splints just down the side of the bone, again, if you can avoid treating through those parts and treat through other parts of the bone, that would be preferable. So it'd take a little bit of creative planning from my perspective, and it's patient by patient. I know we do get patients like this in my department, and it's really just a conversation you have as a team to figure out how we're going to work with this. It's always a challenge in those situations. So, but Sergey, I don't know if you've got any advice from an oncologist.
No, I think that's a good way to really see the problem. It's challenging, patient specific and technology specific. So it could be quite challenging sometimes, but what you said is correct. You do the best with the case you have in front of you if you approach it in a multidisciplinary fashion, taking into account the physicists, the radiation oncologists, and the therapists, and formulate the best solution for that challenge you have in front of you. I think that's a great way to approach it. And I think that one of the questions was, what about prosthesis in vertebral body and spinal cord behind? I think the same concepts apply. So sort of taking case by case basis and do the best what you got with the technology you get. I think that's at least the beginning of that conversation. And then there was a conversation more related to planning. Is it possible to apply MIP to all structures of interest in a tumor bed during the CT imaging before the process of contouring and treatment planning commences, to avoid all this confusion about artifacts? So MIP as a solution of all these artifacts, what do you think?
I've never tried that. So like MIP is really to do with motion rather than tissue artifacts. So like you'd use an MIP, I guess, like we were talking about last week in motion management. So you'd have your different CT scans, and if you've got a lung patient, you might use MIP to create your ITV or something like that. MIP is not super useful in terms of removing artifacts based on different tissue densities. So I don't think that's going to be a solution in that issue. So shame, it would be nice if that worked.
It would be nice. It's an answer for a different question.
Yes.
And then I'm going to briefly ask two questions. I'm going to fuse them together, and I think the later part of the question is going to allow you to go on with the lecture. So what is the difference? Very basic, very important question. What is the difference between MV and KV, megavoltage versus kilovoltage? And then joining that with, under what situation can an MV based image be advantageous in modern LINAC machines over KV imaging?
Ooh, good questions. Okay. So the first question, the difference between MV and KV. So MV is obviously your megavoltage radiation. So that's the radiation you're using to treat the patient. KV is kind of your diagnostic imaging kind of energy. So the energy that you might use for your CT or a normal orthogonal X-ray. So MV traditionally has just been used to treat patients, and we've taken advantage of the fact that there's radiation passing through the patient to create an X-ray image using an MV beam. So, and I guess my slides will probably help answer that question as well. So I might move on to the next question about what situation can MV be advantageous over KV? That's a really great question. The advantage with MV is that MV images are in the plane of the treatment beam. So you are seeing the radiation image as you are treating the patient. So like I said, we can use cine images on our MV EPID panel. So we can actually get a movie of how the radiation is passing through the patient in real time. Whereas KV is a separate unit. So it has a different, I guess, orientation on the patient as opposed to the treatment orientation. So it's kind of at 90 degrees to that. And again, I think these slides will probably cover this as well. So the advantage of an MV image is it is the treatment image that you're looking at. So you know exactly where the radiation is passing through the patient during treatment. And that's a really big advantage in a lot of cases. So I think a combination of the two is the perfect solution, but there is certainly a place for MV imaging, and it will stay in radiation oncology for a long time to come. KV images are beautiful and obviously look a lot nicer than an MV image, but they are not the treatment beam. And it's really important to get that information from the actual treatment beam in an MV image. So it's a really good question. But I can't remember all my slides, but I think maybe I might cover it in the next slide as well. So it's a good segue for me to keep going. So we'll now talk about a KV-based imaging system. And this is when we're talking about KV-based imaging for treatment. So this is now not a CT scan. This is not a C-arm or anything else. This is KV imaging on our treatment system. So KV radiation provides better image quality than MV radiation. This is why we use KV images for diagnostic X-rays. They're really good. You get really good images. And this is mostly because the photoelectric effect is more dominant at KV images rather than Compton scatter, which is more dominant at MV images. So the photoelectric effect is really, I guess, the direct absorption of photon radiation, whereas Compton scatter means that your photons are scattered and then radiation is absorbed from the scattered radiation. So, excuse me, with the photoelectric effect, you're getting direct radiation absorption. So you get a much clearer picture and you get better soft tissue contrast with KV. So KV radiation reduces the patient dose, although it's not a major reduction in dose relative to the overall dose that your radiation therapy patients are going to get. So I know diagnostic imaging, they're all concerned about patient dose with KV imaging, but to be honest, it's not really a huge concern in radiation therapy cases. And KV images provide a better match to the DRRs from a treatment planning system, mostly because it's a KV image on the CT compared to a KV image on the treatment unit. So you're kind of matching like with like more than an MV image. So you can see on this slide, we've just got some different images. So this is the same patient, one with a KV image. So you can see we've got this really great contrast. You can see all the ribs. You can see, really good skin, patient skin surface, things like that. And here's our MV image. So it's really, the spatial resolution is not nearly as good. They're quite markedly different. You can't see the ribs at all in the MV image, either the AP or the lateral. But you can see the lungs and you can still see a lot of information. Okay, so I just want to quickly cover image quality and KVP, so photon energies for KV. So KVP is the highest or the peak voltage that's applied to the X-ray tube. So this is the voltage that accelerates the electrons from the cathode to the anode, and then hits the target and creates the photons. So if you have a high energy or a high KVP, these photons are more likely to pass through the patient. So the higher the energy photon you have, the more likely it is to pass through the patient. It's stronger, it's going to penetrate deeper through our patient. So a higher energy more likely to pass through the patient, meaning you're going to have less patient dose because there's more photons passing through the patient than being absorbed by the patient. This means that more photons reach our detector system, which is really good for patients that are, thicker parts of the patient, for example, the pelvis. If we have a low energy photon beam, low kVp, the radiation is more likely to be absorbed by the patient, which improves contrast, which is what we saw in that previous slide where we had the kV versus the MV. So the kV, you could see all the contrast with the ribs and the soft tissue. So lower kV gives improved contrast. And you do get strong attenuation and absorption in bone and metal because of the photoelectric effect. So you can just see here, we've got all our photons passing through. We've got low energy. A lot of the photons are being absorbed in the patient. So we've only got a few reaching our detector here. If we have a high energy kVp beam, more of the photons are going to pass through the patient and reach our detector here. So for example, here we have a low energy kVp beam. So you can see in bone, which is, high density material, more of the radiation is going to be absorbed. So less photons are going to come out as they pass through bone. Through fat, which is a little bit less dense, we'll get a few more photons, and obviously air is not very dense at all, we'll get more photons. So in a low energy beam, we get improved contrast between bone and soft tissue. If we have a higher energy kVp, you can see that there's not a lot of difference between the amount of radiation passing out of the bone, the fat, or the air. So you see we've got this decreased contrast and resolution with our higher energy beam. And it's particularly marked here because you've got lung, which has a lot of low density material. The other thing that we look at when in terms of kV images is our MAS. So this is really related to the number of photons that the patient's being exposed to. So kVp is about the energy of the photons, and the MAS is about the number of photons that are reaching the patient. So the higher the MAS, so MAS is current times exposure time, the more photons that are produced, the more photons that are incident on the patient. So if you have a higher MRS, you've got more photons. So obviously more photons are going to reach the detector. You're also going to have a higher patient dose because you've got more photons being exposed to the patient. If you have a lower MAS, you're going to have less photons reaching the detector, and you'll have a lower patient dose because they're just exposed to less photons in general. So looking at, again, a couple of images. So here's our original image. This is an image where we've reduced the MAS by half. So we don't have enough photons in this image. Okay, there's not enough photons hitting the patient and then not enough photons hitting the detector. So the image is underexposed. If we double the MAS, we have more photons reaching the patient and then more photons reaching the detector. And in this case, we have too many photons reaching the detector and we have an overexposed image. So it's a fine line between getting the right kVp and the right MAS for different body parts and different scenarios in a patient to get the best image quality. So let's now apply that to our onboard imager. We call it OBI. So this is a kV imaging system that's mounted directly onto the linear accelerator. So it's two arms basically on the left and the right that extend from the gantry of the linear accelerator. So one arm contains an X-ray tube and the other arm contains a kV detector. So the thing with our onboard imager is it rotates its separate arms. So the isocenter of the kV unit, so the central part where I guess the unit rotates around itself, must match the MV isocenter of the linac. So you've got an isocenter between your treatment head and your EPID, and then you've got a different sort of axis of rotation of your kV tube and your kV detector. So you've got to make sure that those two ISA centers align. If they do not align, then the images you're taking with your KV unit and the shifts that the KV unit is saying you should make won't correlate to actual correct shifts in your MV. So it's really important that those two things are aligned. And physicists spend a lot of time making sure that they are aligned. There's a lot of tests that we do. So the KV detector can create an online 2D image to help verify the patient setup. And this image can be compared to the DRR from the planning system, created at a suitable angle, because obviously, because it's at 90 degrees to the treatment beam, you have to create a different DRR for your KV. Like say you're treating at gantry 0, you're going to have to create a reference image at gantry 90 to mimic where the actual KV system is. So you have to remember that when you're creating your reference images as well. So another thing that the KV system on the Linux can do is create what's called a cone beam CT. So obviously we thought, wow, we've got this KV image system that's rotating around the patient. It's a little bit like a CT that has a KV image that rotates around the patient. So a long time ago, someone thought, wouldn't it be good to get a 3D image of the patient on treatment? Then we can compare that directly to our CT image that we've created from the patient before treatment. So what we can do is we can use the onboard imager to create a CT style image of the patient. So we saw at the start of this lecture, so normal CT scanners use a narrow fan beam of radiation. So remember, we've got our source up here with a very thin fan beam of radiation and the detectors that sit on the other side of the patient. Remember, you get that single slice image that you get through the patient. And then the patient moves through the CT scanner to generate more and more slices. So on a Linac, because again, our KV images are mounted sideways, the treatment couch can't move when the KV beam is on, because the couch will actually hit the KV imager. So instead, it's going to have to create a cone beam CT from a sort of a single arc arc. So instead, a cone-shaped beam is used to generate a volumetric image set. So rather than a fan beam, we use a cone beam to create, I guess, reconstruct a CT of our individual patient. So that's why it's called a cone beam CT, because it's a cone-shaped radiation beam rather than a fan-shaped radiation beam. Okay, so if we've got this wide cone beam, we need to be able to correct for any thickness changes in the patient as they cross the beam. So this is where we have things called bow tie filters. So bow tie filters, some Linacs will have automatic bow tie filters that will automatically come in when you take your cone beam CT, depending on the manufacturer. Others you have to physically put in the bow tie filters before your cone beam CT. So the idea of these filters is it improves the cone beam CT image quality. It reduces dose to the skin and reduces scattered radiation. It acts a little bit like a compensator in that the edges of the cone beam are passing through less tissue, and so you add a little bit of attenuation at the top. So it's acting a little bit like a compensator in the image creation. So there are two types of bow tie filters that your onboard imaging system will have. So one is called a full fan bow tie. So that's this one here. So we use that when we've got small field scans where the patient volume is entirely covered by the detector. So our detector size is only a certain dimension. We can't make it bigger and smaller. So if we have a part of the patient that's bigger than that, we need to take multiple images. So, but if we have a small part, so a head where the head volume is entirely covered by the detector, we use a full fan bow tie. So you can see on both sides, we've got less tissue passing through the edges. So that's where we kind of put our compensator in. If we have a large field scan where only a portion of the volume is covered by the detector, so sort of your pelvis and more of your body scans, we use a half fan bow tie. And this is because obviously the middle portion of the beam is passing through the thickest part of the patient, and then the edge of one side is passing through the thinner part of the patient. So we only have to use a half beam bow tie. So there's just some examples of what they look like. It's nothing fancy. So in a regular CT, so in our diagnostic CT or the CT we take before we treat our patient, the fan beam of radiation is so thin, our slice is so thin that any variation in patient thickness across the beam has minimal impact on image quality. When we're using a wide uniform cone beam, we do need to correct for these varying patient thicknesses, otherwise you get imaging artifacts. So that's when we use those bow tie filters. So like I said, it's really compensating for the lack of tissue on the edges of the field as we move around the patient. Oh, am I going backwards? You've just got double slides in there. Okay. So like I've said, in small field scans where the patient volume is entirely covered by the detector, we use a full fan bow tie filter. So one like this. So, you know, it rotates around the patient and we get this image. If you do the same thing with a half band bow tie, you'll start to see some imaging artifacts. Or if you don't use a bow tie filter at all, you'll see some imaging artifacts because you'll have part of the beam being covered by higher intensity radiation than other parts of the beam. So you'll get a ring artifact at the edge of the image. And it gets brighter as the filters are reduced from full to half to none. Okay, if we have a large field scan, where only a portion of the volume is covered by the field detector, we use a half fan bow tie. So in this case, because we're only passing through half of the patient. So if we accidentally use a full fan bow tie filter, you're going to see this beautiful ring artifact and not get a lot of information inside the image because we're attenuating the beam too much. And without a filter, there's a high attenuation at the center and less towards the edges. So you'll get another ring artifact there as well. So if you do a cone beam CT and you see an artifact, maybe the first thing you go is, did I have the right bow tie filter in? Do I have a bow tie filter in at all? So there's some things to think about when you're taking a cone beam CT. So just another, I guess, picture of how the setup all looks. So we've got our MV source up here, our treatment radiation is passing down. So our MV detector's down here. And then we've got our KV source and KV detector sitting at 90 degrees to those radiation beam paths. Okay, so let's look at all the different imaging techniques that we can have on a LINAC and the advantages and disadvantages of each of those. So we've got our portal images, so our MV. So the advantage of this is thicker patients. You can get radiation passing through thicker patients rather than using KV beam. You can use it for visualization of prostheses and confirming gaps, which we talked a little bit about before. You can get direct field verification with our MV images, and this is really important because it's what you're actually treating the patient with is what you're looking for. You can monitor treatment in this way. Like I said, we use like cinema type images throughout treatment of our patients, so we can monitor the treatment as it's happening. Another advantage of portal images for you physicists out there is you can do a lot of your LINAC QA on your EPID. So in my department, almost all of our like monthly LINAC QA is done on the EPID. All our patient-specific QA for all of our IMRT, VMAT, SBRT patients are done on the EPID. So it's super efficient, actually a really big game changer for time effectiveness. So the disadvantages of obviously using MV images is the low contrast that we've talked about. It is more dose to the patient if you're taking extra images. Obviously, if you're using the treatment images, it's no more dose to the patient. And obviously, the MV images are 2D type images. With your KV, so just your straight KV image, obviously you're getting that really great contrast between soft tissue and bone that you don't see in MV. there's less dose to the patient, and you don't get the artifacts that you see in the MV images. Disadvantages is it's 2D images again. Cone beam CT, you get really good contrast, you get really good spatial resolution. It's a lot easier to compare it with the 3D image set that you've created in your planning CT. Disadvantages, obviously you get metal artifacts, and they're less easy to correct on a cone beam CT than they are on a standard CT. And you do get more dose to the patient from all the cone beam CTs that are taken. Okay, so another Zoom poll question.
Let me pull it up.
Perfect. So in this question, we've got an image here. Okay, so it looks pretty light, maybe. So what would you do to improve the quality of this KV image? So would we increase the photon energy or decrease the photon energy? Would we increase the number of photons, the MAS, or decrease the number of photons? So remembering the very beginning, I was talking about when you have more photons hitting your imaging plate, the image is darker. Maybe that's a little bit of a hint, maybe too much of a hint. We're finished?
Yeah.
Oh, people are still typing. Perfect. Okay, so all of you legends that said you would increase the MAS, you're totally right. Well done. Oh, someone's scribbling on it. Oh, hang on. Yes, so in this case, you would increase the MAS. So you can see the original image was very light. Like I said, when the photons hit the plate, they make it darker. So in this case, it looks like we need to have more photons hitting the plate, right? So this is an underexposed image. So in this case, a 6 MAS gives us a really good exposure. If we go way over, like 24 MAS, we've got an overexposure there. So well done. People know your image quality. Perfect. All right. All right. Sorry, I'm very conscious of time. No, I always go over time. I'm sorry.
You're good. This might be a good time to bring in a couple of questions.
Okay. Yes.
All right. So let me go to my notes. So the questions that have come across in the last 10, 20 minutes have to do a lot with the imaging. So we talked about the difference between MB, KB, and then they were coming back some of those important questions about the bolus. So I think it's just for clarity, it might be worth asking the question because that question has been asked again. On the question of placing a bolus, what if the bolus is placed in the right area, but there are air gaps? What would happen with the dose?
Oh, good question. All right. We like bolus, I see. Okay. Oh, look, bolus is very tricky. And it's the same as even having a mask. Like if you have a head and neck patient and you've got a cast on the patient, that's like teeny tiny bit of bolus you've got right there. Like the cast is acting as bolus because it's not skin and it's a little bit of thing that's going on in your patient. If you're talking about a teeny tiny air gap, it's not going to make a huge deal of difference. Teeny tiny air gap is not going to make a great deal of difference. If the air gap is significant, and I don't even know what you deem significant, 5 millimeters. You know, I guess it depends how thick the bolus is. Well, let's say if it's 5 millimeters, you will start to see a little bit of a hot spot appearing on the skin surface. Okay, if you remember back to our images at the very beginning, where you're going from water to air to water. You'll get that hot spot kind of coming as you pass through the air onto the skin surface. So you'll just get a little bit of a hot spot, and your skin will be a little bit hotter in that area where the air gap is. But it's very difficult to place bolus perfectly on the patient for every fraction also. So I think over time, those air gaps are probably not always in the same location on the patient, depending on what sort of bolus you're using. So if you're using superflab or some kind of soft bolus, I would expect that the air gaps are going to shift around the patient for each different fraction, right? So then that would mean that those hotspots are spread over the patient throughout the course of treatment and probably insignificant. If it's hard bolus and it's been made in that way and you've permanently got an air gap in the same location, I think it would be a good idea just to see if you get any skin reactions around that area. So if you're treating, say, a head and neck patient and you're seeing a skin reaction in a certain part of the patient, maybe have a look, and it got bolus, maybe have a look at the bolus there, and you might find that there's a little bit of an air gap that might be causing that skin reaction. So so air gaps, generally what you'll see is you'll get a little bit of increase in skin dose because of that difference jumping from water to air back to water in that way. So hopefully that answers the question.
Yeah, I think it does. Next question. Can the MV parameters be changed like the KB parameters?
No, not really, because the MV beam is your treatment beam. So it's the beam you're treating with. You really can't change that. And we certainly don't like to change our MV parameters because our MV beam has to match our planning system. So no, unfortunately, there's not a lot you can do in terms of changing the actual MV parameters to improve the image quality. So good question though.
That's clear. And the last question I have for this round is, what is the difference between applying KBP and KBA in imaging, and what risks abound in using KBP in imaging procedures?
KVA, I'm not sure what KVA is. Chris, maybe you're going to have to email me and we can have that discussion, because I think I'm going to have to look that one up for you. So Chris, if you could email me, I think my email address will be at the end of these slides. Send me an email and I can talk you through that one.
Okay.
Because I don't want to give you wrong advice. I'm going to have to look that one up. I'm sorry.
Okay, can I just say something?
Yeah.
Can I go on?
Yeah, of course you can.
Okay. What I know is that, when you are using KV peak, there's tendency that the tube can burn because of surges in current inflow. So it is safer to go through a KVA when there is still some space that can accommodate surge, in case there's a surge into the system that cannot be controlled.
Okay. I think I'm going to have to probably have a chat with our engineers about that one. It's a really good question, and I don't think probably in a lot of hospitals in Australia and probably in the US as well, we have a lot of surge protectants and things like that inbuilt into our electronic systems. So I don't think KVA is something that's really considered. So Chris, if you can email me and I'll have a chat with our engineers and just get their thoughts on it, if that's okay.
Okay, that is okay. And secondly, regarding this MV, in true beam linear accelerator, we have a portion where you can go as low as 2.5 MV. In case you want to use the MV imager, not for treatment, but for imaging now. In the true beam linear accelerator, there's a part of it where you can step down from 6 MV to 2.5 MV to now do imaging, which is a little bit safer for the patient. So there's a provision for that with the true beam linear accelerator by Varian.
Okay. I would probably still suggest using a KV rather than an MV for imaging. Like 2.5 MV is still going to give your patient a fair amount of dose that I'm not sure your planning system may necessarily account for. So I'd probably be using a KV imaging rather than a 2.5 MV imager. Even if it's an option, it's probably not something that I would choose to do. I'd prefer to go with a KV imaging. Okay.
And there's a question I asked about applying MIP during CT processes. You know, what I mean by that MIP is applying the maximum intensity pixels to any suspicious thing around the tumor bed to know whether it's a bone, or whether it's a soft tissue, or whether it's a calcified thing tending towards becoming bony and all that. So that if all that are applied, you know, applying MIP will now mean giving it the right Hounsfield number, so that you're doing simulation, doing the treatment planning and the contouring, you can probably be known that this is actually a bone, this is actually a calcified tissue tending towards a bone, which may be cancerous. So when doing the system planning and then the optimization process, we now know, okay, this is not actually a bone, but this is actually a tumor that's getting too calcified. So we now know the approach or the dose that will be applied to it without affecting the surrounding tissues. So that's my own idea.
Oh, it's your own idea. Chris, you're super clever. I would think that your RED to HU curve would probably do the same job. So you'd have your Hounsfield unit to relative electron density curve that you would categorize for each individual energy of your CT unit. And so it would create those for you rather than having to use an MIP. But it's a really good thought. I would also think that like the image processing software within the CT itself would probably account for a lot of those things that you're talking about as well. So it's probably very specific to individual CT manufacturers and the processing software that they have.
Okay.
If that makes sense.
Thank you.
Yeah.
Yes, it does. Thank you very much.
No problem.
And I believe we have someone who would like to ask a question. Surrender, please feel free to unmute yourself. Unless he's not asking to.
It's just waving.
Just waving, I guess. All right, we can move forward.
Okay, we're ready to do the final stage?
I think so.
Okay, let's go for it. All right. Okay, so this is just going to be the start of Introduction to Image-Guided Radiotherapy. Like I said, I think probably almost the next few lectures are going to be covering this as well. So I'm not going to be going deep into it. And I'm not quite sure what the following lectures are covering, but I know they're really talking quite heavily about it as well. So I'm just skimming the surface, really. Okay, so we've talked about uncertainty and error in radiation therapy, all right? There's many sources of uncertainty and error in radiation therapy. A lot of this then results in how we create the margin between our GTV and our PTV and things like this. So there's uncertainty when we're doing our contouring. Okay, there's uncertainty with the radiation oncologist drawing in the contours of our tumor. There's uncertainty with drawing in the contours of our organs at risk. There's uncertainty in the microscopic extent of the tumor that forms part of our target volume. There's variation both interfraction and intrafraction in the positions of internal organs at risk as well. You know, you've got bowel filling, bladder filling, gas moving through the patient breathing, respiratory movement that we talked a lot about in the last lecture. We've got positioning patient errors. There's always uncertainty in all of these things. So the ability to take images in the treatment room immediately before the patient is irradiated increases the chance of knowing the exact location, extent of the tumours and organs at risk that you're about to treat. So what we're talking about in image-guided radiation therapy is image verification done before, during, or after treatment. So we're really guiding a whole treatment based around these images. Okay, so how does it work? So we take our image acquisition, okay, so using our MV or our KV that we've just talked about. It provides information on the position of the tumour and healthy organs. Now, it might be surrogate information. So, for example, if we're using MV images and we're looking at bony anatomy, it's not going to tell us the exact position of the tumour, but it's a surrogate for where the tumour lies in comparison to bony anatomy. Okay, so then we have image registration. So this is where we match the image of the patient or the tumour on the treatment couch to the position of the patient or the tumour on the treatment plan. So when they had their original CT. And then what we do is we apply any intervention. So we reposition the patient and apply any couch translations in order to get those two things to match up and improve our patient positioning. So in terms of image acquisition, the first priority is to see what you are treating. If you can't see what you're treating, then the images are fairly useless. So we can use our EPID MV imaging. We can use KV imaging with our OBI, our cone beam CT. We can change parameters for image quality. We can use fiducial markers or bony landmarks as well. So if you want to do full 3D verification, at a minimum, you will need to take perpendicular images, so an ISO pair, to correct in the 3 directions, so X, Y, and Z. If you want to do more precise 3D positioning, then we use our cone beam CT. Okay, that's our first priority, get good images. So our second priority is to minimize dose to the patient. So the big question is, should I lower the frequency of imaging to lower the dose to the patient? The answer is no. Okay, our first priority is accurate patient alignment for treatment delivery. So this is the most important thing. Okay, the dose to the patient that they get from imaging is around about less than 1% of the dose for each fraction that the patient is being treated for. So the dose from the treatment far outweighs any dose from the imaging verification. So it's much more important to have the treatment dose delivered accurately. So if you're giving less than 1% of the dose to verify the patient's in the right position, that's great. Because if you don't do that and you treat the wrong part of the patient, that's really bad. So it's more important to make sure that the dose you are delivering is being delivered to the right position in the patient. Otherwise, you're going to do a lot of damage to your patients. So in terms of doses, what kind of doses do we actually give for these imaging techniques? So if you're taking a film, so your port films, your cassettes, whatever, per image or per fraction, it's around about 50 to 100 milligray per fraction. So our EPID has drastically reduced the amount of radiation we need to take with our MV images. So we're now down to 10 to 50 milligray per fraction. It's not a lot of dose. With our KV images, say we use 100 to 200 kVp and 10 to 20 MAS. If we take a single 2D image, we're getting around about 1 to 2 milligray per image. So if we do an ISO pair and apply this daily for 30 fractions, we get 30 milligray. So this equates to 1 film or 3 port images. So it's not a lot of dose. And if we take a cone beam CT, we can get 5 to 50 milligray per fraction. So again, these are not big doses that we're getting with our imaging techniques. Okay, so we talk about image registration. So I'm just introducing all these terms that you're going to hear over the next couple of presentations. So image registration is a process where you overlay 2 or more images from various imaging equipment taken at different times and angles, and you geometrically align them for analysis. So image registration involves mapping points from one image to corresponding points in another image. So whether this is looking at bony anatomy, whether it's looking at fiducial markers or other landmarks, you map them on one image, you find them on the other, and then you join them together. So it takes the different image sets and transforms them to a unified coordinate system. So let's say you've got a coordinate system on one image and your fiducial markers have certain coordinates from that coordinate system. You've got your second image and your fiducial markers have coordinates from that coordinate system. You then correspond and unify those coordinate systems. So the shifts between the two different coordinate systems in order to align those two images can then be directly related to the patient shifts that you need to do on the treatment couch. Okay, I think I have an example. I'll keep going. Registration is necessary in order to be able to compare or analyze the data obtained from different image sets. So in treatment verification, we want to compare the patient position from the treatment plan, our planning CT, to the patient position on the treatment couch. So we need to register the image sets to each other. So this can be done in different ways. So there's manual registration. So manually moving one image set to match the other. So where you click on the page and, you know, it's kind of fun, actually, kind of like snapping them together. There's automatic registration. So this is where the computer software uses algorithms to look at each individual voxel in an image to determine the best match. Super fancy, probably faster than manual registration. There's two different types of automatic registration you can do. So one is called rigid. So this is where it keeps the distance between every pair of points in the patient's anatomy the same. So it's just taking that image and just moving them in those dimensions. Then you have a thing called deformable registration. So this allows non-uniform mapping between images to better correct for small spatial discrepancies. So that would be like saying I've got my hand like this and my hand like this, and I deform this hand like that to match them together. So not only do I turn my hand and match it, but I also deform it in this way to match it. So that's what deformable image registration is. So it's not just a straight kind of shuffle them together, but it actually starts to deform parts of the image to better match the two images together. We don't use deformable image registration for treatment verification because it takes a while and it's quite complex, but two, you don't want to deform your patient image because you can't deform your patient at the time of treatment. You know, what you've got at the time of treatment is the patient anatomy. You can't deform it to match another image. So you're really just figuring out the best position for that patient to be in to closely match your treatment plan. So there's no point deforming a patient verification image because you can't deform the patient. You know, you've got what you've got and you just have to register it. But I just wanted to highlight that there is another type of image registration. And you'll see deformable more in treatment planning, just within a treatment planning system. So maybe deforming an MR image to a CT image and things like that, but you wouldn't use it in treatment verification. So just a bit of a workflow. So you've got your planning CT. In your CT room, you do your contouring and you create your plan. Then you'll go to the treatment room. You might have a pre-treatment cone beam CT. So we've got our planning CT here and our cone beam CT here. You can see it's not the full image of the patient. That's the limitation of our imaging panel for the cone beam CT. And then we will try and register those two images together till they match. So you can see here, you know, we're shifting, creating shifts, and we've got a match here. And the way we've had to shift this image to match this one is then the position that we shift our patient on the treatment couch, or the shift we make to our couch to match our patient together. So you can do this using an ISO pair, so a 2D to 2D match. So the coordinate shifts to match the planning DRR on the treatment images are given as couch position and rotation shifts. It's a little bit hard to see down the bottom here, but you've got the shifts that are required to match, that are required to move the two images so that they match together. So we're talking about very small shifts of, less than a millimetre in vertical and longitudinal, lateral, and even rotational motion of the couch. So some Linacs, depending what Linac you have, will allow the automatic couch motion to correct the patient position. So you'll take your images, the system will work out what the shifts are, and then they'll say, do you want to apply the shifts? And you hit yes, and the couch will automatically move. You don't even have to go in the room. Other Linacs may require the RTTs to manually go in and make those shifts to the couch. It just depends on the Linac that you have. And also depending on the treatment that you're doing, some radiation oncologists would like to see a post-shift verification image. So particularly, say, if you're doing cranial SRS and things like that, you're treating multiple lesions in the brain, super, high doses and, super difficult to do. Often the radiation oncologists want to double check. So you've taken your first image, you've done your shifts, and then you just want to take another image to verify those shifts have been made correctly. So depending on the treatment that you're having, sometimes you'll have two images before you even start treating. So you'll have the first one to find out what shifts you need to do. You'll make the shifts. You'll take a second one to confirm the shifts have been made correctly as well. The same thing with a cone beam CT, so a 3D to 3D match. So the shifts are then determined on 3D image matching directly compared to your planning CT. And again, depending on the treatment technique, you might take a post-shift cone beam CT as well to verify that the shift has been made correctly. So same process. All right, I think we're nearly there. So just really the take-home points from this particular session is obviously imaging technologies has changed over the years for simulation treatment planning. If you want to do IMRT or VMAT, you really need CT images. So CT images are a must for inverse treatment planning. We could talk about MR only treatment planning. That's a whole nother session that we won't be going into at this point. Imaging technology has also changed imaging for treatment. So we've got our MV and our KV Linac mounted imaging systems. These are also a requirement for IMRT and VMAT treatment verification. And then I've quickly just introduced you to the concepts around image guided radiotherapy. So your 2D to 2D matching or your cone beam CT matching in improving patient setup accuracy for IMRT. And that stuff will be talked about in the session. I think it's next week as well. So I think maybe, see, look, we've got all these sessions coming up on IDRT. It's excellent. It's a lot of fun looking at images.
That's right.
So I didn't want to go too much into it because you're really going to have another three sessions covering this stuff as well. So really, I just wanted to introduce the concepts to you. So I think that's it. I do have, and they will appear in the slide list from RCC. I do have a couple of extra slides that are just showing you again some differences in imaging parameters and things like that, image quality. So, but I won't go through those now because I'm very conscious of the time. So we always go over time.
No, this is great. Very, very good interactive lecture, tons of good content, tons of good questions, great discussions. I really appreciate all of this. Do you think we have a few minutes for the outstanding questions that have been shared with us?
Of course. Yes.
Awesome. So a question has been asked. How many slices obtained through cone beam CT?
I'd have no idea. I'm sorry.
I think it all depends, right?
Yeah, I think it depends on the
and the settings and many factors.
Yes. Yeah. I'd just be throwing a number in the sky, really. So I'm not going to say one.
It varies.
Yes.
Next question. If you density override air cavity in order to achieve good dose distribution, don't you think that it does not reflect the real situation?
Oh, right. Yeah, good question. No, I didn't say to override air cavities. I said just to contour them and remove them from the PTV. So if that's a genuine air cavity that is going to exist in the patient throughout treatment, you do not override an air cavity. So the only things you would override are imaging artifacts. So you wouldn't necessarily override air cavities. So the things we look at overriding in my department are imaging artifacts related to streaking effects from high density material, or if you have contrast in a patient, you would contour the contrast and override the density of the contrast, because that's not going to be there during treatment. We often override air in the bowel because it's an assumption that the air in the bowel is not going to be there during treatment, or it's not going to be consistently in the same place during treatment. So that would be the only time we'd override air, is overriding air in the bowel or the rectum in the treatment plan, and only in the areas that are directly impacted by the radiation beam. So I would never override an air cavity that exists in every single fraction of the patient. So I would never override like an esophagus or anything like that, because it is what it is. But I would, if the radiation oncologist agreed, I would remove that air cavity from the PTV just to improve the dose distribution. So
yeah, I think that brings the concept, just to bring it up, of PTV evaluation, meaning just look at the metrics without doing override on really the planning, but just knowing what is the dose distribution where it matters. At air is not part of the tumor, and it's not part of the target, it's not part of the patient that needs radiation. So, but it doesn't mean that the dose distribution doesn't go there. It's just for evaluation of that PTV might be subtracted. So it's hinting towards that.
Yes.
We do have a couple of more questions. How do you match the images based on bony anatomy or soft tissue?
Oh, I can see you've already kind of started to answer this one. And you're absolutely right. It depends on what it is you're treating and what it is you're interested in. So obviously matching bony anatomy is infinitely easier than trying to match soft tissue, because it's so much easier to see, right? So the majority of automatic image registration software will look at bony anatomy because it's just so much easier to see. There was an interesting case I had in my department a couple of weeks ago. We had a cervix patient, vulva. And we were using bony anatomy to match to the CT, but there was so much swelling in the vulva that actually the soft tissue was sitting probably 1.5 centimeters beyond where the PTV was contoured, based on bony anatomy matching. So in that instance, we had to move to soft tissue anatomy matching, because that was what we were interested in, was the soft tissue, and the motion of the soft tissue compared to the bony anatomy because of swelling actually meant that we were going to miss part of the PTV. So it really is kind of dependent on the area that you're treating. So do you agree, Sergey? Am I
100, 200, 300%.
Yeah.
I like
bony anatomy match is much easier,
okay.
but you know, most of the time you're not treating the bones, so you have to consider both.
Relevant for some cases, exactly.